Hello and welcome to this Langford Academy video on pleural effusions. My name is Jenny Reeve. I'm a specialist in internal medicine at Langford Vets and I'll be walking you through this session. We've split this session into 3 videos, the first looking at patient triage and assessment, the second looking at thoracentesis and how we safely and effectively perform this skill, and the third looking at effusion analysis and classification so that we can move forwards diagnostically and therapeutically with these patients. So in this first video, we're going to be reviewing patient triage and assessment. Patients with pleural effusions can present with a real spectrum of clinical signs, and these can be signs that are either confined to just the respiratory system or just the thoracic cavity, or they can be more systemic depending on what disease process they've got going on. In terms of their respiratory presentation, we can see a range from really mild tachypnea, so mild increase in respiratory rate, through hyperpnea, so increased respiratory effort, orthopnea, where they adopt a stance in sternal recumbency with abducted elbows to reduce the pressure of their forelimbs on their chest and therefore reduce the work of breathing, all the way up to overt dyspnea, so breathing difficulty that may be accompanied by open mouth breathing and extreme respiratory distress. The classic pattern that we see in patients with pleural effusions is that of a restrictive respiratory pattern. So we get the impression, as in this cat here, of a degree of blunting to the excursions the thoracic cavity exhibits during breathing. In terms of other concurrent intrathoracic signs that the patient may present with, it's actually really quite uncommon for patients with pleural effusions alone to present with coughing. So if we're seeing a patient who we've identified to have a pleural effusion that is also coughing, we'll be really suspicious for an underlying pulmonary disease such as pulmonary neoplasia, or an inflammatory disease such as a migrating foreign body, an abscess or pneumonia, and those diseases have extended to include the thoracic cavity and result in a pleural effusion. The clinical presentation of patients with pleural effusions can be really varied in terms of the onset of the disease as well. So we can see peracute respiratory difficulty and dyspnea in patients with pneumothoraces, and that can be whether they're spontaneous, so for example secondary to bleb or bulla rupture in a dog, or secondary to spontaneous lung rupture as a result of inflammatory airway disease in cats, or of course secondary to trauma. Or we can see peracute dyspnea again if we've got development of a hemothorax, which usually results in a relatively large volume bleed, and we can see that secondary to either coagulopathies or structural underlying intrathoracic disease, particularly neoplasia or granulomas that can bleed. Or we can see a more chronic insidious progression if, for example, we've got the development of an inflammatory pleural effusion, so such as a pyothorax, or if we've got something like a chylothorax that may be associated with congestive heart failure or other causes. We may also sometimes be in a position where we are specifically looking for effusions as a presentation in patients with a multisystemic disease, or for example, where we are imaging the thoracic cavity for another reason and we identify a really low volume pleural effusion. And in these cases, although it may not be causing any clinical signs, identifying exactly what that effusion is can really help us move forwards and achieve a diagnosis for that patient so that we can move forwards therapeutically as well. So one of our main aims when we're assessing patients that may be at risk of dyspnea are that we minimise the stress that we cause to them as much as possible. And the reason for this is these patients can often already be heavily compensated and be on a knife edge between being able to tolerate their pathophysiological disease process versus decompensating and potentially going into respiratory arrest. So our hands-off assessment is a really valuable part of our assessment to facilitate our ability to observe both their mentation and their respiratory pattern and try and get a bit of information from that. And during that, we're going to want to minimise the extent that we restrain them and provide oxygen. And for some patients, particularly really stressed and smaller patients, so cats or really small dogs, this may mean actually putting them in an oxygen kennel for a short period of time to observe them for a number of minutes while we're getting ready to sort of assess them further, may be really valuable to them. Alternatively, we can provide oxygen flow by if they're happy sat on the table. One of the first things we're going to want to be observing is their respiratory pattern. So what phase of respiration is the dyspnea? If the dyspnea is inspiratory, that suggests an upper respiratory location of the dyspnea. If it's expiratory, it suggests a lower respiratory or pulmonary parenchymal cause of the dyspnea. If it's restrictive, this suggests a pleural cause of the dyspnea. And these aren't necessarily hard and fast rules, and we can see, particularly in patients with pleural effusions, some of them can appear to have a more expiratory rather than restrictive pattern. We're also going to be wanting to pay particular attention as to whether there's any paradoxical respiratory effort. So have we got concordant movements of the chest and abdomen? They're both moving out and in at the same time. Or have we got evidence of a more seesawing motion of the chest and abdomen, where as one moves out, the other moves in, which is an indication of a paradoxical breathing pattern and a flag for respiratory failure. So we certainly want to be mindful of those patients. In terms of other hands-off assessment, we've mentioned just briefly assessing the patient mentation and whether this is appropriate, and then also use this time as an opportunity to observe for any other really notable abnormalities. So external wounds, ability to ambulate if the patient sort of stood up, although obviously at this stage we're not going to actually get them down on the floor and ask them to do those things, but it may be readily apparent if they're holding a limb up, for example, they've suffered some suspected trauma. In terms of ongoing oxygen provision, we'll start, as we've said, with flow-by or an oxygen cage. But as we move forwards with these patients and we sort of stabilise them and want to look at providing, in those who need it, longer-term oxygen support, the use of nasal oxygen prongs or nasal oxygen catheters, which can easily be connected to our wall oxygen supply, are really valuable. Once we've done our hands-off assessment, we've got a brief idea of the localisation of the problem. We're going to want to move forward with a hands-on assessment. So this can be a matter of seconds or minutes after the hands-off assessment, depending on each individual patient. And this is going to focus on core cardiorespiratory triage. So their respiratory rate and effort we've covered already, but their heart rate, their pulse volume, is it synchronous to the heart rate? Do we have any arrhythmias, etc.? And also their mucous membrane alongside their pulse volume as an indicator of peripheral perfusion, remembering that pallor can be seen not only with anemia but also with sort of peripheral perfusion deficits, so hypovolemia or other forms of shock. In terms of auscultation, this will come after our hands-on assessment. So this is where we'll be listening for arrhythmias, and this is where we may want to auscultate the chest as well to evaluate for any sort of respiratory sounds or absence of that may indicate a pleural effusion, or specifically abnormal sounds that may help us get a bit more information as to the patient's underlying disease. So are there crackles suggesting sort of lower airway or pulmonary parenchymal disease? Are there wheezes to suggest sort of lower airway disease? During this phase, and we may want to prepare for this at the beginning of the hands-off assessment, in order to facilitate the hands-on assessment, we may want to consider anxiolysis for these patients. So something like butorphanol, or if we're worried about trauma and pain, a full opioid agonist will be beneficial. Once we've done these brief patient assessments, we're going to want to think about sort of respiratory side patient diagnostics. So things like, is it feasible and easy for me to get a pulse oximetry reading on this patient? If not, I'm going to provide oxygen for them anyway, but that may be something that's helpful in terms of quantifying degree of respiratory function in a sort of broad and crude sense. We may want to consider a point of care ultrasound scan. These are hugely valuable and very rapid diagnostic assessments that can give us a really good amount of information, which we'll review as we move through this video. We may, once they've been stabilised, feel that we want to get a minimum database. So for example, blood gas analysis, including blood glucose, PCV, total solids, and placing an IV catheter so that we're better able to manage these patients can also be really valuable. And in patients who don't want to be restrained, particularly around their front end, this is where lateral saphenous or medial saphenous catheters, depending whether you're a cat or a dog, can be really helpful because we're not having to restrain the patient's head while we're placing those catheters. So point of care ultrasound scan is performed routinely. This is a technique that was originally described in human medicine to be used in the trauma setting as a really urgent triage for patients who may have internal bleeding. And over time it's evolved to enable us to not only use it for that purpose, but also to look for effusions due to other causes, actually also perform lung ultrasound as well. So this is very much sort of moved forwards over time. So when we're talking about point of care ultrasound of the chest, we are talking about 5 different sites, and we perform this in sternal recumbency. This patient here is in lateral recumbency for demonstration, but ultimately we've got our diaphragmatico-hepatic site that is just caudal to the xiphoid pointing cranially. That's going to enable us to evaluate for pericardial and pleural effusions, potentially abdominal effusions as well. And then bilaterally, we've got 2 sites. So we've got our chest tube site, which is at the 7th to 8th rib, about 2/3 of the way up the thorax, which is where we're going to evaluate for our glide sign, which we're going to talk about as we move forward. So we're going to check that we have got lung interface here and that the lungs are contacting the chest wall. And we're also able to ascertain whether the lung tissue looks normal or not. And then we've got our pericardial site bilaterally, which is where we would palpate the apex beat, which enables us to look over the site of the heart, but also look ventrally in the chest for effusions as well, so for fluid. There's also a lung ultrasound technique described, so VET Blue, so basic lung ultrasound exam, and this describes 4 sites on both sides of the chest that is specifically to look at the lung parenchyma itself. So the point of care ultrasound sites in the T-FAST, the ones we described on the previous slide, are very much looking for, is there pleural space disease? Is there an effusion? Are my lungs touching the wall of my chest? Whereas the VET Blue is described to better evaluate the lungs, and we use these 4 locations on both sides of the chest to enable us to have assessed all of the lung lobes really that are available in the dog or cat for assessment. So when we're talking about interpreting our thoracic ultrasound, one of the first things we do, put our probe on the chest. We want it in a horizontal plane, and really we're looking for our PP line, so the pleural pulmonary interface line, which is this bright white line at the chest wall on the video on the left here. And we want to see that sliding side to side across the screen, because that enables us to know we've got lung there that is gliding on the internal aspect of the thoracic cavity. This video on the left here shows essentially what a normal lung looks like. So we have these sort of horizontal and parallel lines, these bright lines through the lung parenchyma that essentially let us know this is aerated lung. It's really important that we're looking for that PP line, the pleural pulmonary interface glide, as it slides side to side, because if we're seeing these sort of horizontal A lines without seeing that glide, we will see that in a pneumothorax. So we need to be seeing the glide to be knowing that it's the lung sliding backwards and forwards along the chest wall. Then we can start looking for pulmonary pathology. So if we want to look for pulmonary pathology, we again see this sort of bright interface line at the chest wall, but we will see these sort of white, so these hyperechoic comet tails, which are also called B lines, which indicate we've got wet lung. And that doesn't tell us what type of fluid is in the lung, whether it's edema, hemorrhage, purulent material. It also doesn't tell us whether this is just highly cellular infiltrates in the lung, as we'll see with sort of inflammatory cells or neoplastic cells, but this lets us know this lung parenchyma is not normally aerated. So we want to be doing this evaluation at the VET Blue sites, and then we also want to be looking at the T-FAST sites, because if we've got the space between the lung parenchyma and the chest wall is expanded by anechoic fluid, then that would suggest there is fluid present and we've got a pleural effusion. We can also use this time as an opportunity to do a basic cardiac assessment, and we're really here looking for a sort of point of care subjective assessment as to our left atrium to aortic ratio, and we can see clearly here in this cat, even just eyeballing this without measurement, we've got a markedly dilated left atrium compared to the diameter of the aorta, and also we've got smoke in this left atrium as well. So do use this opportunity to look at other structures within the chest.